What does the patient population look like for this procedure?
Well, I think the patient population is obviously a collection of patients with arthritic change in the knee, specifically unicompartmental disease, either in the medial aspect of the knee primarily, or some of the newer techniques with arthritis in the lateral side of the knee as well, but specifically unicompartmental. It's also a patient that has reasonable expectations as far as pain relief. It's basically to get them active again, but not necessarily from a complete pain relief type of procedure. It's basically a person who wants to get back into more reasonable activities of daily living, walking, say being out with the family, being able to bike, possibly swim, that type of patient. It's not designed for a patient who wants to go back to running, as an example. That's basically too much pounding, too much heavy activity. And it basically is in a patient population that really is not ready for a true bone cut type of replacement.
What is the ideal patient profile for this procedure?
That's an interesting question. I think, again, it needs to be somebody that has a reasonable want for back to more normal activities of daily living without the pain and dysfunction that comes from unicompartmental disease. I think that in the experience that I've had, not only with OrthoGlide but other types of unicompartmental replacements, I think that actually a little bit older female, maybe a little bit on the slightly above ideal body weight, a bit, possibly a little bit shorter leg, seems to do very well with this. Also, interestingly, a relatively tall older male is not a bad candidate. I think that, again, it comes down to expectations. It comes down to a little bit of laxity, just a touch in the say on the medial side of the knee, in the medial compartment, so that you get a better balance after the replacement goes in. I think all of those factors are important in trying to pick that specific patient. But again, it's somebody that really just wants to improve their activities, will accept some degree of residual pain, possibly in their knee, and basically doesn't want to try to believe that they're 15 years younger than what they were before, because it's not really designed to go play basketball again.
Does the implant stay in place?
Absolutely. I think that certainly the company's done extensive studies with the stability of the implant. Certainly that in other preceding products that were out on the market, that was a lot of the problem with them, was the instability that created in the joint. And I think that the posterior flange, or the lip that fits over the back of the bone, has been just a wonderful design. It stays flat on the tibia. I've had absolutely no problem with it. In all of the implants that I put in, both in the research lab as well as in patients, I've been very impressed as to once it's in, it truly is in. When you get it in and say in the lab want to take it back out and look at it, it's pretty hard to necessarily get it out, which is I think borne out by the clinical results that have come to date, which have shown excellent stability in the joint.
How difficult is this procedure?
I think that the procedure is straightforward. I think that there are certain techniques where you need to be exacting with it, but they're not difficult techniques. I think the arthroscopic portion of it is straightforward. I think that the keys to the procedure are certainly cleaning the posterior capsule off of the back of the joint, all the way from the PCL fossa back underneath the original root of the medial meniscus, around to the attachment of the capsule to the deep fibers of the medial collateral ligament, because that, again, that posterior flange, which is what's all about its stability, needs to sit completely over the back, so it's a very important thing to do. I think that the right angle rasp that's been designed by the company to do this is a very good instrument to do it, and it's easy to do. I think the arthroscopic portion as well, to be able to remove the residual of the medial meniscus out to a very thin rim to surround the joint, It's easy to see, easy to do. Some of the removal of the articular surface, again, arthroscopically, technique-wise, not a problem. Once you get into the mini open portion, you can certainly see fine. You can make some final adjustments in the joint. You know, the final congruency rasps, the ability to you know, machine the joint ever so slightly. Fairly simple. It's easy things like a range of motion, stability testing. You can easily open the medial side just gently by releasing a bit of the MCL. I find it pretty straightforward, so people who are comfortable around the knee are going to do very well with this implant.
What is your clinical experience with this product? Do patients get pain relief?
Number one, yes, patients do get pain relief. They get a variety of different kinds of pain relief. In particular, I've been surprised that a few of my patients have actually gotten complete pain relief. I think that the clinical studies from long ago with metal implants of joints have started to pave the way for an OrthoGlide component to become available. And those long-term studies in patients have shown that metal on bone can produce pain relief, and the OrthoGlide does indeed do that. I think one of the things that needs to be stressed for patients is the acceptance of the implant in the joint, not from where it sits or the stability of it, as we talked about, but rather from how the joint experiences that new pressure, probably the new pressure sensation, is variable in patient to patient. And I think that you know, part of it, by helping to manage patient expectations a bit, will probably lead to a better acceptance of it. And ultimately, as time with the joint in the knee progresses, I found that people do better and better and better, and can get to the point where they really do have a pretty significant experience with pain relief.
What do you think is the mechanism of pain relief with this product?
I think there are a lot of factors that get involved with that. I think that the redistribution of force in the joint by a realignment, if you will, by reestablishing some of the height in the medial joint space, certainly directs pressure to the lateral side of the knee, as an example. I think that's very important to redirect the forces. I also think that the you know, the studies that prove that the coefficient of friction of bone on metal is a much better number than bone on bone, and I think that those type of mechanisms are perceived by the compressive force realization, if you will, of the joint space, and so that combination of factors ultimately is realized by the knee in its own perception, which ends up in an actual reduction in the pain perception from the joint itself. So I think it's a combination of factors. Metal on bone is better than is better than bone on bone, and also to redistribute the force by the increasing size in the affected compartment.
How do you manage patient expectations?
I think that number one is I think it's information and education for patients. I think that people need to know what's a reasonable outcome for them. I think they need to realize that it's not like a bone cut procedure that probably denervates the joint to some degree. It's not going to denervate the joint. The joint is still going to have some sensations. I think that people need to realize that ahead of time. So I think that it's very important to help them understand that they're going to have certain sensations yet from their joint. I think that to help them understand that you need to go slowly with it and be tolerant of it for a certain period of time, I think is important. I think it also needs to be very clear to people that they have to manage a bit their own activities. I mentioned it before, such things as running or impact pounding is really not the way to go with this joint. So setting it up beforehand is important, and I think that once that it's in, to see people back in the clinic and just be encouraging of their activity and help them understand that some of the things that they still feel in their joint are not unusual.
Can this procedure be performed under local anesthesia?
I think that it could. I personally have not done that in my patient population. I think that the route that I have taken mainly with my patients has been spinal anesthesia. I have, however, done some fairly significant cases just under local anesthetic in the joint. I think that there are some cocktails of local anesthesia that can be injected and done reasonably well. I don't see any reason why they couldn't be done under local. I think that the amount of actually having to work a little bit with bone, such as where you may have to rasp down the front corner of the tibia right at its corner with the anterior cruciate ligament as an example, may be a spot where you could otherwise create a little bit of a sensation from the bone doing it that may or may not respond terribly well to a local, but I don't see where it would be a major reason not to try it and get some experience with it. Like I said, I have not, but I certainly don't think that it would be out of bounds at all.